Hello, everybody. Welcome to this discussion where we're going to be looking at approach to a respiratory system case examination. Like all the previous cases or all the previous discussions that we've had, I will be presenting a dummy case wherein it's going to be just like you will present a case in your exam. And along with that, we'll be discussing approach to a child who presents with respiratory complaints. And the discussion is going to be a holistic approach, not just related to this particular case, but all the points that are pertinent to the respiratory system, history taking, and examination. So let's begin. Okay, so for this case, let's say it's a 3-year-old boy who is first by birth order, resident of Mumbai, informant being the mother, who's reliable, who's brought in with chief complaints of fever since 5 days, cough since 3 days, and hurried breathing since 1 day. So the chief complaints are fever, cough, and hurried breathing. Now, with these chief complaints in mind, what do we think or what system do we think is primarily involved? So, which system is involved? So, with fever, cough, and hurried breathing, most likely it's involving the respiratory system. Now, in the respiratory system, is it an involvement of the upper respiratory tract or is it involving the lower respiratory tract? Now, what exactly do you mean by when I say an upper and a lower respiratory tract? So, anatomically, you can broadly classify the respiratory tract into upper, which is anything that extends from the nose up to the larynx, whereas a lower respiratory tract is involving the trachea up to the lungs. So, depending on the site of pathology, we can say whether the involvement of the respiratory tract is upper or the lower tract involvement. Now, let's look at how we describe each and every symptom in detail so that we get more information as to what exactly are the chief complaints. And it will also help us in probably localizing the lesion as to whether it's an upper or a lower respiratory tract, and will also give us insights into more specific details about what is the site of involvement, what is the type of pathology, and what exactly we are dealing with. So the first complaint that the mother gave was cough. So how do we describe the cough in detail? The first, like any other symptom, we always describe a symptom in the order of ODP, which is onset, duration, and progress. So cough has been present for 3 days now. Okay, so the onset. So first point is about onset. So was it sudden onset or was it a paroxysmal or an insidious onset cough? So sudden onset cough, the causes like written here could be either choking or foreign body aspiration. Whereas a paroxysmal cough, which is like, insidious in onset, will point towards a more infectious etiology. It could be bacterial, it could be viral, or it could even be asthma. Now, what is the duration of cough? Is it acute or is it chronic? So the cough which is persistent for like less than 2 weeks is classified as acute cough, whereas chronic cough is any cough that has been present for more than 2 weeks. So it's important to differentiate whether it's an acute onset of cough or whether the cough is chronically present, because the reasons or the causes of acute and chronic cough are different. Somebody who's suffering from chronic cough has a more long-standing illness. It could either be asthma, it could be a foreign body aspiration, it could be a chronic um, underlying etiology like a cystic fibrosis, a bronchiectasis, or probably even tuberculosis. Whereas a short-term infectious etiology like a bacterial pneumonia, a bronchiolitis, or a viral infection would have a more acute and shorter duration of cough as compared to somebody who's having a long-standing illness who will present with chronic cough. Now, the next thing is a little tricky, especially with respect to pediatrics. So, whether the cough is wet or dry. Now, what exactly do we mean by wet cough and dry cough? So, usually when the airway produces secretions, particularly the lower airway, that's when you have that wet cough with mucus expectoration. Whereas dry cough is usually the irritant cough that is present when there's irritation of the upper airway. So usually they say that when you have a wet cough, it is involving the lower respiratory tract, whereas a dry cough is more suggestive of an upper respiratory tract. Again, there is no 100% rule to this, but that's what it kind of signifies. But because in children, they don't expectorate cough. Okay, so say a 3-year-old will not be able to take off the cough. So then how do you differentiate whether it's a wet cough or a dry cough? A crude way of differentiating this is by asking the mother whether she feels that, the chest is full, and whether she can hear the chest vibrate, or she can, feel the chest vibrating when the child is coughing. That's a very crude way of asking whether, you feel, or the mother feels whether the cough is wet or dry. And other thing which is important, especially in the smaller kids, is something called as post-tussle vomiting. So what happens is that children who are less than 5 years of age cannot expectorate cough. So they're not going to be able to throw it up. So what happens is the cough is swallowed and it may come out in the form of vomitus after repeated coughing. Okay, so because the child is not able to throw up cough upfront, what happens is they swallow the cough and it might come out as vomitus when there's repeated coughing and repeated irritation. So post-tussle vomiting is another very important question to ask, especially in younger kids, less than 5 years of age, who are not able to expectorate cough. Now, is the cough associated with noisy breathing? So there are various differentials for noisy breathing. The three most common ones would be stridor, wheezing, and grunting. Now, what is the difference between these three? Stridor basically is a harsh sound that is produced because of the turbulent flow of air across the larger airway. So stridor predominantly is an inspiratory sound that arises from the larger airways. So it's basically involving the extrathoracic airways or the upper airways is when you have production of stridor. On the other hand, wheeze is more of a musical noise that's produced predominantly from the lower airways and it's heard major in expiration. So that's predominantly the difference between stridor and wheezing. And other important sound that we should be aware of is grunting. What exactly it is when the child is breathing against a closed glottis. What does grunting signify? Basically, it's the attempt that the patient is making in order to keep the alveoli open. Otherwise, the alveoli will completely collapse and there'll be no exchange of air. So the body is trying to maintain PEEP. What do I mean by PEEP? It's the peak and expiratory pressure, so as to keep the alveoli open. Grunting usually happens when there's a parenchymal or an alveolar involvement, like we see in pneumonia. So the three important sounds or three important differentials of noisy breathing would be stridor, wheezing, and grunting. So if you look at this beautiful diagram of representation of what noisy breathing looks like, so you can have stridor and wheezing. Again, stridor, like we discussed, is an upper tract involvement predominantly involving the larger airways, and it's a harsh sound produced primarily in inspiration again. You can have stridor, which is biphasic and also heard in expiration only, but predominantly stridor is heard in inspiration, whereas wheezing is a musical sound that is heard arising from the lower airways or intrathoracic in location, and it is predominantly heard in expiration. So these are the causes of stridor, and these are the causes of wheezing. Uh, the causes, like we saw, are different, and when exactly you hear the noisy breathing, whether it's inspiration or expiration, also will give you some kind of insight as to what kind of pathology and where exactly is the anatomy of the lesion. Having said that, it's difficult for the parent or the informant to give you exactly what kind of noisy breathing it is. So it's going to be difficult to differentiate only on the basis of history, whether it really is stridor, wheezing, or grunting. But definitely, you can ask for whether there's a history of noisy breathing associated with cough. And when you examine the child, you'll be able to differentiate whether it's a stridor or whether it's a wheezing, and then localizing the lesion and your differential diagnosis will vary accordingly. But it's always safe to ask the informant whether the cough is associated with noisy breathing or not. And then you should know the types of noisy breathing and how do you differentiate the two, and how is it important and why is it important to differentiate, because both of them will tell you a different story and you'll be able to localize the lesion based on just the type of noisy breathing that you can hear. The next question that you ask in cough is, what are the aggravating relieving factors? Now, dust, allergens, seasonal variation, exercise, etc., can exacerbate asthma. So, those children who have asthma or who have allergic conditions, there might be certain allergens that exacerbate the lesions or exacerbate the condition. The common ones being dust, allergens, or even seasonal variation. So cough, that is, probably this is not the first episode of fever, cough, and hurried breathing. The child has had cough multiple episodes in the past. Is a known case of a recurrent visa or has asthma, then you should always ask for aggravating and relieving factors. Last but not the least is the cough. What is is there a diurnal variation in the cough? Now, why is it important to ask? Because GERD or gastroesophageal reflux disease, the cough in GERD typically worsens when the child is made to lie supine, and asthma predominantly has nocturnal cough. So somebody who's coming with this history of nocturnal cough or cough which is worse but the child is like supine should give you some hint as to what the underlying differential or the diagnosis could be. So this is how we describe cough in detail. The next symptom that the mother gave was fever. Now, again, fever becomes very important, and there are specific questions that you need to ask, which will again give you insight as to whether the etiology is viral or bacterial. Now, let's look at how. So, three important questions that you ask with respect to fever are: what is the grade of fever? Is it low grade or high grade? What is the interfebrile period looking like? Is the child active in the interfebrile period? Is the child playful? Or is the child lethargic, unable to feed, and toxic looking? What is the response to antipyretics? Now, why are these questions important? Is because you will be able to differentiate a viral versus a bacterial infection. In bacterial infection, usually the fever will be high grade. The child is more sick, more toxic looking. The interfebrile period is also not going to be very good. So the child might be lethargic, fussy, decreased appetite. So the sicker the kid, the more it points towards a bacterial etiology. Whereas in a viral infection, usually the fever is low grade. The child is active in the interfebrile period and there's good response to antipyretics. So important questions with respect to fever are these three, which will be able to differentiate whether it's probably a viral or a bacterial etiology. The third thing is hurried breathing. So the mother also complained of hurried breathing since one day. So hurried breathing could be either in the form of increased rate of breathing or it could be chest indrawing. So you need to ask the informant as to why does the mother feel that the child is having rapid or hurried breathing? Is it because she feels that he's breathing fast or is it associated with chest indrawing or chest retractions? That's something you need to ask. Was the onset of hurried breathing insidious or sudden? Now, again, like cough, if there's sudden onset hurried breathing, it could either be because of foreign body aspiration, choking, or trauma causing pneumothorax. Whereas if it's a more insidious onset, it points towards a more of an infectious etiology. What is the progress? Has the hurried breathing been the same since the time it started? Is it improving? Is it worsening? And what are the aggravating and relieving factors? So, for example, somebody who has asthma, nebulization will improve the hurried breathing, whereas feeding may exacerbate the hurried breathing in certain conditions. So, aggravating relieving factors become very important and should be asked for any symptom that the informant is telling you. So, we saw the detailed questions that you need to ask with respect to cough, fever, and hurried breathing. Now, having described the symptoms in detail, let's look at the history of etiology. So, we saw that most likely, this is involving the respiratory tract. It could either be upper or lower. Having said that, it's always important to know that any patient who's presenting with hurried breathing or rapid respiration or tachypnea, like we call it, is more suggestive of involvement of the lower respiratory tract. Basically, it's the lung parenchymal involvement, and that's why hurried breathing points towards the possibility of a lower respiratory tract involvement. So what questions do we ask for history of etiology? So for an upper respiratory tract, you will have associated ear pain, ear discharge, nasal discharge. So does the kid have those things? If they have, then again, it points towards probably the etiology being a URTI. History of choking, regurgitation of feeds or vomiting to rule out GERD. Now, along with just respiratory tract involvement, what if the child also has an underlying cause which predisposes the child to, say, a respiratory tract infection? Okay, so let's say the child has an underlying heart disease, whether cyanotic or acyanotic. If we go back to the discussion of an acyanotic congenital heart disease in the previous class, we saw as to why they are at a higher risk of having recurrent respiratory tract infections. So, how do you ask for history of probably an underlying acyanotic CHD, history of suck cycle, forehead sweating, difficulty feeding, decreased urine output? All of these point towards the probability of having an underlying acyanotic CHD, which is predisposing the child to having a respiratory tract infection. Next, for a cyanotic CHD, history of bluish discoloration of lips or extremities, which refers to cyanosis. Other than that, two important questions that you need to ask: if the child has chronic cough or has other associated features like weight loss or failure to weight gain, failure to thrive, or Cox contact. Now, remember, um, these are points that you will not ask if a child is presenting with an acute history of fever, cough, cold, and hurried breathing for a week. Like in this case, where we have fever for 5 days, cough for 3 days, and hurried breathing since one day. But somebody who's presenting with chronic cough, and along with cough, they have failure to gain weight, failure to thrive, they're losing weight, or there's significant Cox contact, that's when you're suspecting tuberculosis and you need to ask for this question. You will not have to ask this if it's an acute history. So remember, history of Cox contact is something that we tend to ask in each and every case, irrespective of whether it's relevant or not. So in an acute, I'm repeating myself, in an acute presentation, you might not ask, or you need not ask this question related to Cox contact. But yes, in a child who's presenting with chronic cough or other associated features, it's always good to ask for history of Cox or Cox contact, especially looking at how prevalent tuberculosis is in our country. And if there's history of infection of other systems. So probably if the child has some kind of an immunodeficiency syndrome, which predisposes the child to repeated infections, along with the respiratory tract involvement, there might also be involvement of the GI tract or skin infections, etc. So if there's history of infection of the other systems in a child who's presenting with cough repeatedly, you can also think in terms of probably underlying immunodeficiency, which is predisposing the child to these repeated recurrent infections. So after history of etiology, we look at history of complications. So danger signs is something that needs to be looked out for in all patients who present to us. So what danger signs will you ask for? Whether the child is poor feeding, vomiting, lethargy, or irritability. Now, irritability could be either because of hypoxia or hypercarbia. When you have low oxygen, it can also predispose to seizures because of cerebral hypoperfusion. And whether the child has cyanosis, which again indicates impending respiratory failure. So, what complications are you worried of when it comes to the involvement of the respiratory tract? It could either be respiratory failure, so it can lead to cyanosis, hypoxia, which will present as lethargy, irritability, seizures, or last but not the least, poor feeding and lethargy. So these are the common questions you will ask the mother to look for complications. And if there are danger signs, then definitely the child is more sick and needs immediate attention. And the line of management kind of changes in first stabilizing the patient and then evaluating as to what exactly you're dealing with. So these are the questions that you will ask with respect to history of complications. Next is treatment history and course in the hospital. So from the time the child is presented to you in the hospital, what exact treatment has the child kind of received, and how has the course been after admission to the hospital? So whether the child received oral, IV medications, nebulization, or has required oxygen support, and whether there has been improvement of symptoms since admission. So let's say the child has received some kind of nebulization and there's immediate kind of relief. It could either be like asthma or it could be bronchiolitis, bronchitis, whereas a more infectious, bacterial infectious etiology will take more time to recover and will have a more prolonged course in the hospital as compared to a short, mild viral infection. So depending on how the child is improving, how there is symptomatic improvement will give you some kind of history, some kind of information as to what etiology you're dealing with, and again, how severe is the lesion. Now, past history. So whether this is the first episode or the child has had similar episodes in the past, if yes, then what kind of treatment has the child received? Whether there has been a need for hospitalization, because that will tell you how severe the previous episodes have been. Like, for example, somebody who has asthma or has recurrent wheezing, they might have repeated hospital admissions for nebulization or receiving oxygen therapy, etc. So that will kind of give you an idea as to whether you're dealing with a chronic condition or this is more of an acute illness. Now, it's a history of chronic drug use. Let's say the child has asthma and he might be on MDIs or metered dose inhalers or the pump, like in layman terms, like the mother will give you a history. Or let's say the child has an underlying acyanotic CHD. That kid might be taking anti-failure medications like diuretics or ACE inhibitors. So chronic drug use will again point towards certain underlying etiology, which has been long-standing. History of allergies, whether it's nasal, skin, or respiratory, points towards more of an allergic etiology like allergic rhinitis, sinusitis, etc. For the weather, there is seasonal variation of symptoms. Again, that points towards more of a seasonal etiology or an allergen, particularly in that particular season, which is exacerbating the cough. History of repeated infections at other sites, like we discussed, gives some kind of insight into probably an underlying immunodeficiency disorder and whether there's history of contact with somebody with tuberculosis. Now, antenatal birth and post history, these questions, so I'm not going to be discussing questions that you need to ask in these because it's pretty much the same as any other case. I'd like to emphasize that a child who's presenting with chronic cough, so one differential could be cystic fibrosis. So when you have a child with cystic fibrosis, they usually have delayed passage of meconium. So normally meconium needs to be passed out in the first 24 hours of life, and the child needs to pass urine in the first 48 hours of life. But let's say the child has delayed passage of meconium. He doesn't pass meconium for the first 3 days. And later on, the child has had repeated episodes of cough, pneumonia, requiring admission or requiring some kind of treatment for that. Then you could probably think in terms of cystic fibrosis. So again, this delayed passage of meconium pointing towards cystic fibrosis, that history again will be asked for someone who's presenting with chronic long-standing cough and not in this case, which is more of an acute presentation. But because it's an important question to ask, I wanted to add it here. But remember, you will not have to ask for this history if it's an acute presentation, like in this case. Again, another important question to ask in the antenatal and birth history is whether the child has required long-term oxygen therapy at birth. So let's say the child was born preterm, had respiratory distress syndrome, required oxygenation, ventilation for a prolonged period of time. Those kids develop BPD or bronchopulmonary dysplasia, also called as chronic lung disease. So these patients might be chronically auto-dependent. They might have repeated infections. So that is again another question to keep in mind for someone who is presenting with a long-standing chronic history, especially if the child was born really preterm and had a stormy NICU course, required oxygen for a long period of time. Immunization history, whether the child has received routine immunizations, and importantly, whether yearly influenza vaccines have been administered or not. Developmental history most likely will be within normal limits. I'm not going into those details because, again, development history has to be taken under all the 4 headings of your gross, fine motor. So, gross motor, fine motor, social, and language milestones. But if everything else is okay and if this is an acute history, then most likely development history will be normal. Dietary history, again, you calculate the calorie and protein intake and deficit. It will give you an idea as to what the nutrition status of the patient is. Because again, malnutrition predisposes to repeated infections. Or again, if a child is having repeated infections, then the child is more likely to be malnourished. So it's like a vicious cycle. So you need to take the dietary history like any other case where you calculate the protein and calorie intake and expected intake and the deficit between the two. Now, with respect to family history, you need to ask for history of tuberculosis, asthma, or atopic dermatitis in family members because asthma and atopic dermatitis can run in the family. So it's important to ask for that history. Tuberculosis, again, because cox contact, because uh, it's so common in the country and it can lead to pulmonary tuberculosis in this patient again, but that history will be more significant or that question will be more relevant in a chronic history. Now, hygiene, overcrowding, smoking, firewood, pets in the household are very specific questions pertinent to the respiratory system. We don't tend to ask all of this in the other systems. But because all of this leads to impaired sanitation, impaired hygiene, which can predispose to infection, these are important questions that you need to ask for in a family history in a respiratory case involvement. Socioeconomic history. So important from an RS case is overcrowding, malnutrition, and hygiene, which plays an important role in predisposition and spread of infection. And what is the exposure of smoking and environmental smoke in the family? Again, these are two specific questions to be asked in a respiratory case. So after having discussed all of these things, where we looked at the chief complaints, the history of presenting illness, history of etiology, complications, treatment history, past history, and all the other left-sided history like antenatal birth, etc., how do we summarize the case? So at the end of this entire history taking, let's say we summarize this as a 3-year-old who's presenting with chief complaints of fever since 5 days, cough since 3 days, and hurried breathing since 1 day. With that, you add significant history of development and nutrition. So let's say child is malnourished. So you say the child is having, with a child who's developmentally normal, immunized for age, who's having protein deficit or protein intake deficit. This case predominantly involves the respiratory system. Now, once you've said that, you need to say whether it's involvement of the upper or the lower respiratory tract. Well, like we discussed, if the child is presenting with hurried breathing, rapid respiration, it more likely shows an involvement of the parenchyma and the alveoli. So it is involving the lower respiratory tract. And again, what do you think is the etiology? Is it viral or bacterial? Now, depending on the pattern of fever and how sick the kid is, you can safely say that more likely if the child is sicker, is pointing towards a bacterial etiology. Whereas if a child is not so sick, doing well in the interfebrile period, the fever is low grade, then it probably points towards a viral etiology. So you summarize this as a case of the respiratory system involving the lower respiratory tract, most likely either viral or bacterial etiology, depending on what you get from your history. So once you summarize the case, let's quickly go on to examination. So general examination, first important point is position, whether the child is comfortably lying in the bed or the mother's lap, or the child is distressed. There is use of accessory muscles of respiration like your ala nasi, flaring of the ala nasi, or use of the sternocleidomastoid muscles, intercostal muscles. All of this will tell you how severe the distress is and will give you an idea as to how sick the patient is. Next important, like any other case, is vitals. So temperature, heart rate, respiration, peripheral pulses, and capillary refill time, blood pressure, and saturation. Now, how do we define tachypnea? Tachypnea definition varies as per age. So a child who's less than 2 months of age, if he has a respiratory rate of more than 60 breaths per minute, that is suggestive of tachypnea. 2 to 12 months, respiratory rate more than 50, and 12 months to 5 years, respiratory rate of more than 40 is suggestive of tachypnea. After general examination, we look at head-to-toe examination. Now, I have also added points in the head-to-toe examination with respect to other pertinent, findings which will not be relevant to this case was presenting as an acute episode of fever, cough, and cold. But it's always good to know more and always good to have a holistic approach. So when you look at the head-to-toe examination of the face, what signs would you want to look at? Okay, so first is something called as allergic salute or Denny Morgan signs. So what does that mean? Now this is a line, on the nose called an allergic salute. So when a child has allergic rhinitis, and they keep sniffing, keep scratching their nose up like this, like you see in this picture, they tend to develop this line on the nose, which is called as an allergic salute. And Denny Morgan lines are transverse lines that originate at the inner canthus and follow the lower lid margins in a parallel arc. So these lines are called as Denny Morgan lines. These are again seen in allergic rhinitis, sinusitis, and eczema. So both of these findings are seen more over in allergic conditions, allergic rhinitis, sinusitis. So in a child who's having say repeated cough along with atopic dermatitis or any allergic conditions requiring, let's say, probably requiring nebulizations or MDIs, it's always good to look for these two signs when you're suspecting a allergic etiology. Now, in the nose, you look for polyps, deviated nasal septum, or any nasal discharge. Look for sinus tenderness. In the ears, you look for any ear discharge. Eyes for congestion and discharge. So, all of this will give you or points towards more of a viral or an allergic etiology. In oral examination, look for cleft lip, palate, teeth, oral hygiene, and thrush. Thrush, you might see your candidal thrush or your white coating might be seen in immunodeficiency, or if the child is having steroid use, so MDIs, when the child is taking repeated meter dose inhalers for asthma, uh, because it's the combination might, so the MDI can be a combination of a beta agonist along with steroid. So prolonged use of MDIs can also predispose to oral thrush. That's why when we prescribe MDIs, we make sure that we give instructions that they need to keep the mouth clean, gargle so that they're able to maintain good oral hygiene. Cleft lip and palate is important because it increases risk of aspiration, so again predisposes to pneumonia. Teeth, oral hygiene is important because again, hygiene is very important. You might be or the child might be aspirating on those anaerobes and oral bacteria, oral organisms, which again increases the risk of infections. So if you look at tonsils and posterior pharyngeal wall, you could look for enlargement and congestion, and BCG scar is important again in our country where tuberculosis is so prevalent. In your pullus, which is your pallor, cyanosis, ictus, edema, clubbing, or lymphadenopathy. Cyanosis, with respect to this case, could either signify severe respiratory failure, impending respiratory failure, or probably an underlying cyanotic congenital heart disease. Clubbing, on the other hand, again points to either a cyanotic heart disease or respiratory conditions like bronchiectasis or cystic fibrosis. We have discussed the etiology and the pathophysiology of clubbing and cyanosis in detail in our discussion of a cyanotic congenital heart disease. So I won't be discussing that in detail again here. But if there are any doubts, you can always refer to that presentation or that discussion. So moving ahead in the head to toe examination, once that is done, we talk about anthropometry. So anthropometry, again, I'm not written here in detail, but we need to look at those same variables. And it's very important to have an interpretation of the anthropometry done at the end of your measurements so that you know exactly whether the child is having acute malnutrition, stunting, wasting, etc. Now, moving ahead into the respiratory system examination on inspection. So first is looking at the respiration. So what is the rate, rhythm, and character? So rate of respiration will tell you whether the child is tachypneic or not, depending on the age-related cutoff like we just discussed. What is the rhythm? Is it regular or is it abnormal like a chain stop respiration? Usually children with a respiratory involvement more likely will have a regular rhythm. Chain stop respiration usually happens when there's a CNS involvement and your respiratory center is involved, and that's why you have this irregular pattern or irregular rhythm of respiration, or less Cheyne-Stokes respiration. Now, what is the character? Is it abdominal thoracic or is it thoraco-abdominal? So usually in younger kids will have more of an abdominal thoracic breathing, whereas as we move more into adolescents and adults, the breathing pattern becomes more thoraco-abdominal. So more likely in younger patients, like in this who's a 3-year-old child, the character will be an abdominal thoracic type of respiration. Now, in inspection, you can also look at the use of accessory muscles like ala nasal, sternocleidomastoid, abdominal muscles. Use of these accessory muscles of respiration will tell you that the pathology is more severe, the child is more sick. What is the tracheal position? Is it central or is it looking deviated? Whether you can see the apex impulse or not. If yes, then where exactly? What is the shape of the chest? Is it normal? Is it funnel shaped? Is it pigeon shaped? Now, abnormalities of the chest shape Again, like points more towards a long standing illness, or probably the child has developmental deformities of the rib cage. So it's always, important to look at the shape, whether it's normal, is it excavated, is it more bulging, what it exactly looks like. Whether the chest is symmetrical, is it bulging, is it flattened, whether there's drooping of shoulder. So if there's chronic collapse or fibrosis of the lung on one side, that particular side will look drooped. So there'll be little drooping on that particular side. So that is again suggestive of a long-standing chronic illness. Bulging or flattened. So let's say the child has had an acute episode of trauma with, pneumothorax. Then probably that side of the chest will look a little bulging, but otherwise, more so, the chest will look pretty symmetrical on both the sides. So, what is the movement of the chest like? Is it equal on both the sides? Is it equal overall or reduced on one side? So, again, if there's, like, say, there's trauma to the chest, there's a pneumothorax, you will have decreased chest movements on that particular side. So, again, it's not very easy to look and differentiate these things, but definitely it's important to look for movements on the left and the right and say whether that's equal on both the sides or decreased on one side or the other. After inspection, we move to palpation. The tracheal position is confirmed. How do you do that? So you take the index finger and the ring finger and place it on either side of the sternocleidomastoid, and you run the middle finger along the center from the cricoid cartilage down to see that the trachea is central, or it can be slightly deviated to the right side, which is normal. However, if you're not able to track or trace, the trachea when you move your finger from the cricoid cartilage down, it will tell you whether the trachea shifted to the left or more towards the right. The next thing is apex beat. So you were able to see the apex impulse on inspection and you palpate for the apex beat in your palpation examination. Next is chest expansion. So how do you do that? So you encircle the chest with the thumb in the midline at the level of the nipple. And then your thumb is right in the center at the level of the nipple, and with your hands you encircle the chest and you see how your thumb is separating with each inspiration. Normally there should be equal movement on both the sides and your thumbs should go out and approximate back with inspiration and expiration respectively. If one particular side is moving less than the other, then it shows that that side is having less movement, and probably that is the side of etiology. Next is vocal fremitus. So what you do is you place the ulnar border of the palm in each intercostal space bilaterally, anteriorly, laterally, and posteriorly. So you do it anteriorly in the infraclavicular, mammary, and the inframammary region. In the posterior aspect, you do it in the suprascapular, infrascapular, suprascapular, scapular, and infrascapular regions, and laterally do it in the axillary and the infraxillary region. So with the ulnar border of the hand, you put it in the intercostal spaces. And obviously, if the child is older, then you ask the child to say 111 and try to feel for the vibration over the ulnar border of the hand. Again, like for example, in a 3-year-old child, like in this case, the child is not going to cooperate, not going to say 111. So another way of doing it is when the child cries, you try to feel for the vibrations on the ulnar border on in the intercostal space bilaterally at the same time. So let's say you're doing it in the second intercostal space, you do it on the left, you do it on the right. You move down to the third intercostal space, do it on the left, do it on the right. So you're able to compare whether you're able to feel more on one side or on the other. Again, these are definitely practical examination tips, but they're difficult to perform in a younger child. As the child grows older and is more cooperative and understanding of instructions that you're giving, these tests become more supportive of your examination. But like I said, in younger kids, it's very difficult to do these examinations. Percussion, again, is all the more difficult to do, especially in younger children. So you percuss with the pleximeter finger, and with the other hand, you hit it as you place it over the intercostal spaces. Now, on percussion, if there's dullness, it points towards an underlying pneumonia or consolidation or pleural effusion. Whether it's more hyper resonant, like it sounds more like there's air underneath, then again points towards pneumothorax. So percussion per se is very helpful when you want to differentiate what is the underlying etiology. So just with your fingers, you'll be able to differentiate whether it's dull or resonant. And it can tell you whether you're dealing with a consolidation or a diffusion or a pneumothorax. Now, tidal percussion is done to confirm the upper border of liver dullness. So if you're having dullness on the right side on percussion and you want to differentiate whether it's because of a lung etiology or whether it's because of hepatomegaly, the best way to do it is by tidal percussion. Again, this is almost close to impossible to doing it in children. Even older children, it's difficult to do. But how do you do it? You start percussing in the mid-clavicular line from the second intercostal space in the right. Okay, and then you stop at the point where you reach dullness. After that, you hold your finger there and you ask the patient to take a deep breath. After taking a deep breath, you wait for about a few seconds and then you percuss again. Now, that point which was dull initially, if it still remains dull, that means you're dealing with uh, mm, it's because of hepatomegaly. Sorry, I got confused. Because what happens is when the child or when the patient takes a deep breath, the lung moves down. So on percussion, you are supposed to get a like a resonant note. But if you still have dullness, if you still have, sorry, yeah, if you still have dullness on percussion with the tidal percussion when the child has taken in a deep breath, it refers to a lung etiology. Whereas if the note becomes resonant, it's because of hepatomegaly. Because what happens is when the patient takes a deep breath, the lung kind of hyperinflates, moves down, and the liver is shifted further downwards. So in that condition, you will have a resonant note if it's because of hepatomegaly. So sorry about the confusion, but if I have to summarize it in 2 lines, if tidal percussion at the end of a deep inspiration, if the note becomes resonant, it's because of hepatomegaly. If the note still remains dull on percussion, it's because of a lung pathology. So that's about percussion. So you percuss in the right and on the left in the supraclavicular, intraclavicular, mammary, inframammary, suprascapular, infrascapular, and axillary and the infra-axillary regions. Now, these are the same regions where you would also do your auscultation. So what do you check on auscultation? First is you look at the breath sounds. Now, whether the breath sounds are absent or present, what is the intensity? Like, is it increased breath sounds or is it reduced breath sounds? And what is the quality? Is it bronchial or is it vesicular? So along with the breath sounds, you also check for adventitious sound, whether you can hear crepitations or rails or crackles. And what is the vocal resonance? So vocal resonance is an equivalent of your tactile vocal phlegmatis, where you put an ulnar border of your finger and you either make the patient say 111 or you hear the child crying. If you do the same thing with the stethoscope and you auscultate, it's equivalent of vocal resonance. So just to quickly discuss what are the type of breath sounds. So you have basically two major breath sounds. You have vesicular and bronchial. Now, normally vesicular breath sounds is what you hear over the lung fields. They are low pitched. The inspiration is longer than expiration, and there is no pause or gap between the two. So normally when you put your stethoscope on the lungs, what you hear is the vesicular breath sounds. Whereas bronchial breathing is basically what you hear when you put your stet on the manubrium sterni or on the larger airways like the trachea. So in bronchial breathing, there is a gap between the inspiration and the expiration, and usually the expiration is longer than inspiration. So when you have passage of air through the trachea or large bronchi, when you put your stet over the manubrium sterni, what you hear is the bronchial breathing. However, when you put your stet on the lung fields and you're able to hear bronchial breathing, you see that in consolidation. Okay, so when there's pneumonia, you'll be able to hear bronchial breathing when you place your stet over the lung fields. So that's not normal. Normally, bronchial breath sounds are heard over the larger airways, but if you hear it over the lung fields, it suggests consolidation, or it could be because of a collapsed lung with a patent bronchus, or it could be a thick walled cavity, again with a connection with the bronchus. So tubular breath sounds or consolidation is what you hear, or is what leads to bronchial breath sounds over the lung fields. Now, this is a very beautiful diagram of what lobes of the lungs lie where on examination. So we know that the right lung has three lobes. So it's divided into upper lobe, right middle lobe, and right lower lobe by the horizontal fissure and by the oblique fissure. Okay. Whereas on the left, you only have a right upper lobe and a right lower lobe. So basically, if we relate this clinically, the infraclavicular, supraclavicular, and the supramammary region basically refers to the right upper lobe, whereas right middle lobe is the mammary. The inframammary region on examination correspond to the right middle lobe. Whereas posteriorly, predominantly your infrascapular region is your right lower lobe, and the scapular and suprascapular areas are your right upper lobe. So how do you differentiate, on examination when you're auscultating or when you're doing a percussion as to where exactly is your site of lesion? So this is a good way of differentiating, on examination whether the involvement is first on the right or the left, and if it's on the right, whether it's involving the right upper lobe, middle lobe, or right lower lobe. Similarly, whether it's involving the left upper lobe or left middle lobe. So just remember this diagram when you're looking at examination anteriorly, laterally, and posteriorly so that you're able to say what lobe of the lung is involved with the pathology. So examination findings in different conditions. So let's say you have consolidation and another patient has effusion. How do you differentiate these two findings? So on the basis of exam, probably they'll present with the same symptoms of fever, cough, and say hurried breathing. Now you have to differentiate whether it's pneumonia or whether it's effusion on your examination. So a consolidation will have bronchial breathing, okay, will have bronchial breath sounds, and will have dull note on percussion. Whereas effusion again will have dull note. So consolidation and effusion on percussion will look the same. They will both have dull note on percussion. But stony dull and non-stony dull is very difficult or almost impossible. It's more theoretical. You can't really differentiate the two only on the basis of percussion. But effusion will have reduced breath sounds, whereas consolidation will have bronchial breathing, louder breath sounds, and that's an important differentiating feature on clinical examination between the two. Because effusion has liquid, which is not a good conductor of air, you will have decreased breath sounds. Whereas consolidation on the other hand has inflammation within the alveoli, which is a good conductor of air. So you will hear louder breath sounds, or what you hear is called as bronchial breathing. So this is how you differentiate consolidation versus effusion on clinical examination. Definitely another way to do it is on X-ray, and we'll be seeing that in the next few slides. But on examination, based on whether you have bronchial breathing or reduced breath sounds, you can differentiate a consolidation versus a effusion. Other systemic examination most likely will be within normal limits. So how do you give your diagnosis at the end of history and examination? So this is a lower respiratory tract infection involving the right or the left side. So let's say involving the right side. Now, depending on your examination findings, which lobe, is it the right upper lobe, middle lobe, lower lobe? Whether it's a consolidation, effusion, or a collapse, whether the etiology is viral or bacterial. What is the IMNCI classification of pneumonia according to your findings? And what is the development and nutritional status of the patient? So let's quickly look at how we justify each and every point in the diagnosis. So based on hurried breathing, we say that there's involvement of the lower respiratory tract. Definitely, whether it's your findings on the right or the left, you'll be able to say that. Lobe involvement, depending on your examination findings, as we just saw in the diagram, depending on where exactly you're able to find your reduced breath sound, bronchial breathing, etc., you'll be able to say whether it's right upper, middle, lower lobe, or whether it's a right upper lobe or left upper lobe or left lower lobe. Now, consolidation, effusion, and collapse. We just saw the difference between consolidation and effusion. Now, how do you say collapse? Now, collapsed lung usually will have the trachea pulled to that side with, depending on whether there's a connecting bronchus. You can either have bronchial breathing or you can have decreased breath sounds. So usually a collapsed lung will have the trachea pulled to the same side. Depending on how chronic the condition is, there might be associated drooping of the shoulder. But usually an acute history of 3 to 5 days more likely suggests consolidation or effusion. And the best way to differentiate the two is based on auscultation, where you have bronchial breathing in consolidation and reduced breath sounds in pleural effusion. Etiology, whether it's viral or bacterial, we just saw that depending on how sick the kid is, what is the pattern of fever, you can say whether it's more likely bacterial or viral. We look at the IMNC classification of pneumonia in the next few slides and what is the development and the nutritional status of the patient. So how do you differentiate a bacterial from a viral pneumonia? Usually a bacterial pneumonia, the child is more sick. You have a lobar involvement. So if you look at this X-ray here, you can see a very well demarcated cutoff area, which is which is the area of pathology over here, which is a bacterial involvement. So bacterial pneumonias have a lobar involvement and they more commonly lead to complications like empyema and pneumatoceles because again, it's a more severe etiology and the kids even clinically are more sick. Whereas a viral pneumonia is a milder illness. You will, or you might also have similar history in other family members. So let's say that along with this 3-year-old, they also have a 6-year-old who's ill. Probably even the mother is down with fever, cough, and cold. On X-ray, they'll have a more diffuse, scattered picture or called bronchopneumonia. You will not have a localized lobar involvement like you see in a bacterial pneumonia. And usually viral pneumonias are self-resolving. They're more of a less severe illness, and the child responds pretty well if it's, a viral pneumonia. Now, what is the IMNCI classification of pneumonia? So, according to IMNCI assessment of a child who is 2 months to 5 years of age, the first thing that you always look for is danger signs. So, you look if the child is able to drink or breastfeed, is the child vomiting out everything, and is the child having convulsions. If not, then you look for or you ask the mother for cough or difficulty in breathing. If yes, then how long has it been present? So that's your history. On examination, you count the breath, you look for chest indrawing, and you listen for stridor. Now, based on this, you can classify the patient as having no pneumonia, pneumonia, or severe pneumonia. Now, if there are no signs of pneumonia or no fast breathing, we just say that the child has cough and cold. If there's fast breathing, depending on the age-rated cutoff, we say that the child is having pneumonia, where the child needs to be given amoxicillin for 5 days and you ask for follow-up. Whereas severe pneumonia or very severe disease is what is something that we're more worried of. So these children will have tachypnea, and along with that, you might either have danger signs or the child is having chest indrawing or stridor. So all, presence of any of these signifies severe pneumonia and the patient needs urgent attention. So based on, let's say this child is a 3-year-old who had a respiratory rate of 55. And I will classify that as severe pneumonia because he's having, so along with that, yeah, if the child is having either any danger signs or is having, let's say, chest retractions or there's stridor, then I'll classify the child as having severe pneumonia and you need to investigate. And like that patient definitely needs urgent referral to a hospital depending on where he's being evaluated for the first time. So let's say the child is being seen at a PHC. If a child is having severe pneumonia, very severe disease, they definitely need to be referred to a higher center where the child needs more investigation and treatment. So IMNCI classification of pneumonia is another question that can be asked, whether you're dealing with no pneumonia, pneumonia, or severe pneumonia. So that classification is something that you need to know. So having said that, after all of this, how do you investigate the child? So what are the investigations that you will send in a child who's presenting to you with fever, cough, and hurried breathing? First, most important investigation is definitely a CBC, and the second thing is a chest X-ray. So what do you look for in a CBC? Two important things that you want to look for is leukocytosis. So if it's a bacterial infection, you'll have elevated WBC count with neutrophil predominance. Whereas in a viral infection, you can either have a normal WBC count or you can either have a slightly low WBC. So depending on whether you're suspecting a viral or a bacterial picture, the CBC picture will change accordingly. Now, the hemoglobin will give you an idea of the nutrition status of the patient. So malnutrition, anemia again predisposes to uh, infections, and it's that vicious cycle of malnutrition. So WBC and hemoglobin are two important things that you will always look for in a CBC in this patient. If you look at the peripheral smear, so two important things in the peripheral smear is if the child has anemia, you look at the peripheral smear picture to look for whether the child has microcytosis, anisopoikilocytosis, hypochromasia, or whether the child is having hypersegmented neutrophils. Look at the cause of anemia. So your microcytic hyperchromic anemia could point towards the etiology being an iron deficiency anemia, whereas hypersegmented neutrophils with the macrocytosis points more towards a megaloblastic anemia. So that's one thing to look for. And second is viral infection can have atypical lymphocytes. So that again can be seen on a peripheral smear. So CBC with peripheral smear is the first investigation that you will do. And definitely the next one is a chest X-ray. So how do you differentiate a consolidation versus an effusion? We saw that on auscultation, you would have bronchial breath sounds in consolidation, whereas you have decreased breath sounds in effusion. Because solid is a good conductor of sound, you'll have increased vocal resonance and tactile vocal fremitus in consolidation, whereas you'll have decreased TVF and resonance in an effusion. Both the pathologies will have dullness on percussion, but if you look at the X-ray in a consolidation, so here you have consolidation in the right middle lobe with air bronchograms. Okay, so you see a heterogeneous opacity, but you can also see air bronchograms, or you can see those streaks of black lines on X-ray, which suggests a consolidation. Whereas a pleural effusion, you'll have blunting of the prostatophrenic angle, and it's going to be a more of a homogeneous opacity without the presence of air bronchograms, which points towards the probability of effusion. So that is how you differentiate consolidation versus effusion on examination and on the basis of a chest X-ray. So another important concept to understand is how do you look at the lobes of the lung on a chest X-ray. So if you look at the blue line, okay, so let's again try and remember what we saw on examination. So the blue line, this represents the right upper lobe. The green line, which is this, represents the right middle lobe. And posteriorly, when we look at an X-ray in the AP view, the orange line refers to the right posterior lobe. On the other hand, if we look at the PA view of the left, so this blue line refers to the right, blue line refers to the left upper lobe, and posteriorly, the orange area refers to the left lower lobe. So, on the basis of clinical examination and on localization on a chest X-ray, you can safely say what lobe of the lung is involved in that respective pathology. After investigating a patient, so yeah, one point I'd like to add is along with these investigations, which are done for an acute setting, let's say the child is having a chronic cough. Other investigations that you might be interested in doing is a Montu test and either a sputum or a gastric lavage for AFB and CBNAT if you're suspecting tuberculosis. Probably even a CRP can help give you an idea as to what kind of an infection. So more severe the infection, like a bacterial infection, you will have a higher CRP, which is an acute phase reactant. So again, it's not a mandatory investigation that you need to do, but remember chronic cough and with a suspicion of tuberculosis, a Montu and a sputum or a gastric lavage for AFB and CBNAT is a must. So after having investigated the patient, how do you treat? So remember, whenever anybody asks you what is a treatment, always categorize the treatment as supportive and specific. So supportive treatment, always first step is to stabilize the airway, breathing and circulation. Depending on the saturation and the clinical condition, whether the child is requiring oxygen therapy. Temperature, so the child is having fever, then antipyretics are important. If the child is dehydrated, then IV hydration or oral hydration is something that needs to be taken care of. And definitely, nutrition and immunization is something that you need to stress on once the child is ready for discharge. Because Immunization will prevent further episodes of infection, and nutrition again is a very important aspect as an overall development and well-being of the child. So let's say the child is malnourished, he is going to have repeated infections. So nutrition and immunization are two things that need to be stressed on to the informant or to the family, especially before discharge and even when the child comes for a follow-up in the OPD. Specific treatment is antibiotics. So most common pneumonia is a community-acquired pneumonia where you have Streptococcus pneumoniae as the most common etiology. So antibiotics, usually ampicillin or cefotaxime, is sufficient. Again, depending on how the child is responding, you might have to change or you might have to taper your antibiotics. So specific therapy will be antibiotics in a bacterial infection, and viral infection usually self-resolving. If there's a suspicion of influenza, then oseltamivir is an antiviral that can be given. So this is the treatment of pneumonia, depending on the etiology and depending on the severity. Now, what complications can you have in a child who has pneumonia? So empyema, effusion, and septicemia or sepsis are the common complications. Again, they're more commonly seen in a bacterial pneumonia, rarely in a viral pneumonia, but yes, you can definitely have them. So we've seen investigations, treatment, and complications. So this basically ends our discussion on approach to a respiratory system, where we've looked at a child who's presenting with a short history of fever, cough, and cold. But along with this acute episode where we finally were able to diagnose this as a pneumonia, we also discussed a little here and there about other points like chronic cough and in history and in examination with relevant Viva questions on treatment, X-rays, and investigations, etc. So this ends our discussion on approach to a respiratory system examination. I thank you all for watching the video, and if there are any questions, any suggestions, you can definitely put it down in the comment box. And if you like the video, please like, share, and subscribe, and you can share the video with the others as well. Thank you so much and have a great day.